are ready.
I'm ready on my end.
Same for me.
Okay. Anybody, any member of the media on who does not have recording rights? Okay, great. Well, then we'll get started. Thank you all very much for joining us this morning to talk about the state of hospitals in Washington State. I am Cassie Sauer. I'm CEO of the Washington State Hospital Association, and I'm really pleased to be joined by a group of hospital leaders and staff from the Hospital Association who are going to provide details on what the healthcare system is facing in Washington State. And our panel today includes Heidi Anderson, who's the Chief Executive Officer of Forks Community Hospital, Bill Robertson, who's the Chief Executive Officer of Multicare Health System, and Dory Undersayer, who's a nurse and the Chief Nursing Officer at Harbor Regional Health. Sorry, Dory, Harbor Regional Health in Grays Harbor. Also joined by Eric Lewis, who is the Chief Financial Officer of the Washington State Hospital Association. Eric was also formerly the CEO of Olympic Medical Center and so has great operational experience. And Shalene Whitaker, who is the Senior Vice President for Government Affairs from the Hospital Association. So today we are releasing the results of our full calendar year 2022 financial survey for acute care hospitals across Washington State. So over the last few weeks, we've been collecting information from our members on their financial performance in 2022 and being able to compare that with 2021. And I always want to remind people that 2021 was not a great year. You look back in your memories, it was a pretty rough year for healthcare. So the fact that 2022 is worse is quite alarming. This is our fourth survey this year. We shared information from the first quarter earlier in the summer, the second quarter last fall, and the third quarter in December. We have really good response rate. Hospitals that represent approximately 98% of all inpatient acute care beds responded to our survey. And the results that we find are clear and incredibly concerning. Hospitals in Washington State are facing an unsustainable financial situation. The financial losses that our hospitals are experiencing continue to be enormous. Revenues simply are not keeping up with rapidly escalating costs. It's most concerning as these large losses are putting patient care at risk in many communities across the state. Hospitals are critical community infrastructure. Washingtonians rely on hospitals to be there for heart attacks, strokes, trauma, appendicitis, cancer, and other emergency and acute needs. Hospitals are the only place to provide care to these patients. There are a lot of folks who provide care in the healthcare system, but when you think about what do you go for a hospital for, there is not an alternative to your hospital for those kinds of services. We're very concerned that access to this specialized care, the highest level of care, and in many cases, the life-saving care, is threatened by unsustainable financial losses as hospitals are resorting to extraordinary means to close the gaps in their budgets. We're already seeing loss of services around our state. And I'm going to turn over to Eric Lewis, who is our CFO, to discuss the results of the financial survey in detail. Eric, please go ahead.
Well, good morning, everybody. Could we share the income statement for 2022 comparing to 2021? Starting with total operating revenue, you can see total operating revenues for acute care hospitals across the state increased by 5% in 2022 compared to the prior year. And total operating expenses increased by 9% in 22 compared to the prior year. These higher expenses were driven by significant increasing costs for staff, energy, supplies, and drugs. Employee compensation increased by 6% in 22 compared to the prior year, while the number of employees increased to over 118,000 full-time equivalents, which was a 1% increase over the prior year. In addition, temporary labor spending increased by 120%. Workforce shortages in hospitals and other industries continue. The rates charged by staffing agencies increased by 22% per hour, and hospitals used 81% more hours of temporary staff. Temporary staff represented 5.5% of hours worked in hospitals in 2022. The net operating losses were $2.1 billion in 2022, which represents a negative 7% operating loss. Let me repeat myself. Hospitals across Washington State had a $2.1 billion loss from operations during 2022. This means that operating expenses were 7% higher than operating revenues. For comparison, in 2022, which was also a tough year, the net operating losses were $742 million, which was a negative 3% margin. These operating losses, combined with significant losses on investment income, resulted in a net loss for hospitals across Washington state of negative $2.7 billion for 2022. This 9% loss is unsustainable. We're already seeing service cuts, limits on hospital admissions, and it's possible that without action, we could see hospital closures. Part of what made 2022 and 2021 survivable were federal relief payments. These payments have ended and hospitals are out of funding. Losses were also offset by revenues from investments. Even the most prudent investments failed to provide returns in 2022. The reasons for these massive losses are many, including low Medicaid reimbursement, as urban hospitals have not received a rate increase in 20 years, and some urban hospitals are paid less than 50% of costs. Hospitals are subsidizing the state's Medicaid program. High inflation and labor shortages resulted in labor, drug, and supply costs rising faster than payment rates. More complex patients whose care costs are much higher than reimbursement, especially from government payers, such as Medicare and Medicaid, who have fixed reimbursement models. The $2.7 billion of losses have resulted in a significant reduction in the cash position of hospitals across the state. Hospitals experienced negative cash flow of $2.5 billion during 2022. This is a structural problem for all hospitals with expenses significantly higher than Medicare and Medicaid reimbursement and expenses growing faster than reimbursement. It's also a national problem. Hospitals across the state are struggling. We expect 2023 to also be a financially challenging year, as expenses are expected to continue to rise faster than reimbursement. Thanks. I think we can stop sharing the income statement.
Thank you, Eric. Shall we go to Shalene now?
So
Thank you.
as you just
Go ahead, Shalene.
As you just heard, we have serious concerns about hospital finances. When hospitals are not financially viable and over time sustain heavy losses, they must either increase revenue or reduce healthcare services, as we have started to experience the loss of services in our state. Reducing healthcare services is an option that nobody wants on the table. So that leaves increasing revenues hospitals receive. Many hospitals across the state have 60 to 80% of their funding that's coming from government programs like Medicare and Medicaid. And these programs have payment rates that don't change and they don't keep up with the cost of care. This is important because one of the main drivers of the $2.1 billion operating loss in 2022 is the fact that most urban hospitals, nearly all of whom are nonprofits, haven't had a Medicaid rate increase in more than 20 years. Hospitals are paid Medicaid rates from early 2000s for 2023 costs. And hospitals at the same time are experiencing record inflation on wages and supplies, as well as other important issues that we use to deliver care. Hospitals need at least $1 billion annually in increased Medicaid payments to help sustain services. And we know that large of an increase would be challenging for our state legislature to fund for hospitals. So WSHA has a proposal to significantly increase Medicaid payments to hospitals without using state general funds. It would work like this. Hospitals would tax themselves and the state would take the dollars and send them to the federal government to be matched, and then return them to hospitals who care for Medicaid patients. For every dollar the hospitals are taxed or assessed, the federal government returns about $3. Nearly every state in the country has these types of programs. They're often called Medicare directed payment programs. WSHA's proposal would bring Medicaid rates up to Medicare rates. And the increase in dollars would follow Medicaid patients, meaning the payment increases go to hospitals when Medicaid patients receive services. So this is the solution WSHA is bringing to the table, to use directed payment program. And we are thankful that our state legislature is taking action to address our concerns. In particular, I want to mention Senator June Robinson and Representative Nicole Macri for negotiating the agreement with us. I also want to mention support for minority leaders John Braun and Representative JT Wilcox. And late yesterday, we reached agreement with the legislature to bring Medicaid payment rates closer to Medicare. And again, Medicare covers about 80% of the cost of providing care. So this legislation requires the support of the legislature. We'll have a bill that'll be moving through the process. Hopefully see that introduced later this week or early next week. And then when the legislature approves this program, we would then go seek federal approval from the Centers for Medicare and Medicaid Services. And if we're successful, Medicaid payments would be increased about a year from now. And so we know that hospitals will need to continue to adjust within their current payment realities. And lastly, while we're enthusiastic about the Medicaid increases that I just covered, this will not make up for the gap that we are seeing between hospital costs and revenue. Hospital losses were $2.1 billion from operations, and the Medicaid rate increases would be about $1 billion a year. So that leaves about $1 billion in terms of losses that this new program would not cover.
Thank you. Good.
Oh, I just said I was going to turn it back to Cassie.
Okay, thank you, Shalene. So we could pause here and see if there's any questions for the WISHA team before we have, as I mentioned, 3 hospital leaders from around the state to talk about how this is hitting in their local communities. But any questions about the information we presented? And I will note that in the chat, you've got the PDF of the information that Eric presented, the financial information. Okay, well, let's start with Heidi Anderson from Forks. Heidi, if you could share with us how the financial situation is hitting your hospital and your community and your patients would be great.
Good morning. My name is Heidi Anderson. I'm the CEO of Forks Hospital, and rural hospitals provide vital connections to healthcare across Washington state. Forks Community Hospital provides emergency services, medical surgical care, long-term care, primary care, radiology, lab, respiratory therapy, physical and occupational therapy, and a few other modalities. We also rely on our larger hospital partners to have beds available when members of our community need a higher level of care. We've already seen what happens when those hospitals don't have capacity. We end up caring for those patients, and sometimes they die in our facilities. I worry what will happen if these financial changes continue long-term. That will mean less access to that higher level of care for members of our community when they need it. There is not a single hospital that hasn't been seriously impacted by the financial challenges brought on by staffing shortages of the pandemic and inflationary pressures. At our hospital, we currently have the most traveling staff we've ever had. Before the pandemic, I could count on one hand the number of travelers we've had in 23 years. Hiring people in rural areas has always been challenging, but it has gotten even more competitive in the last 3 years. No hospital likes having to use contract labor. We would much rather employ nurses and other professionals than to bring in temporary help. However, we need people to take care of our patients, and the fallout from the pandemic is that we needed to bring in more temporary help even as we work to recruit, retain employed staff. In 2021, we brought our entire organization up to market, meaning both of our contract labor unions. Again, in 2022, we brought our nursing staff up an additional 17%, and again, applied market increases across the organization. We are not unique in making these kinds of investments in our staff compensation. Wages have moved up much faster than inflation and certainly much faster than reimbursement from Medicare and Medicaid. We've seen hospitals across the state reduce beds and close services, including critical services like labor and delivery, which we've had to shutter for a short time because of nursing labor. Labor and delivery is an especially difficult service to maintain in rural areas, given recruitment and the cost challenges. Long term, If we are not able to address the systemic reimbursement issues we're talking about today, I am concerned about our ability to maintain services in our community and the ability of our patients to access a higher level of care when needed. We may be separate organizations, but we are all part of a system of care across the state, and we need all parts of the healthcare system to be supported to care for our communities. Thank you.
Thank you, Heidi. And as we all learn, you probably hate when people say this, as we all learned from the Twilight books, it is a long way from Forks to another place for healthcare. And so when your healthcare services are closed, it's a really big deal for a population that's very underserved and very much in need of care.
Yes.
Thank you very much.
Thank you.
From a perspective from a much larger system, but that it serves has a big statewide footprint, Bill Robertson, the CEO of MultiCare Health System.
Thank you, Cassie. Good morning. My name is Bill Robertson. It's my privilege to serve as the CEO of MultiCare Health System. If you don't know MultiCare, we do provide services all the way in Eastern Washington to Central Washington to the Puget Sound. We've been in the providing care since 1882 with the establishment of our first hospital. And as you've already heard, the healthcare ecosystem in the state of Washington is under great strain, as it is throughout the whole United States. And MultiCare has not been immune to this. All of our hospitals in 2022 lost money on an operating margin basis, and our aggregate loss was $286 million. Clearly not sustainable over time. We're fortunate to have had a stable balance sheet, so we've absorbed that in the near term, but it will not last, and we won't be able to sustain it over time. Second only to federally qualified healthcare centers, MultiCare is the largest provider of care to Medicaid beneficiaries. So the fact that Medicaid has not had a rate increase since 20 years is dramatically impact on our organization's ability to be financially stable to meet our community's needs. If we had not raised the wages of nursing for the last 20 years, you'd think we were crazy, and we would be crazy. And I think not raising what hospitals get paid to take care of the most vulnerable in our communities has been a disservice to the healthcare capacity to take care of our communities. So inflation has been dramatic, as has been referenced. Between 2019 and 2021, we saw a 17% increase in costs without any corresponding increase in the rates that were paid. It is very interesting how you work in a market economy when it comes to supplies and wages and benefits and energy costs and all the things that are necessary to run a high-functioning community asset like the hospital. And our revenue is largely not in a market. It's just set by regulated governments through Medicaid and the Medicare program, and it has not kept pace with the needs of the community. So about a $2 billion shortfall in the state of Washington related to Medicaid payments, which becomes a tax on employers who buy commercial insurance, because they are ultimately have to make up the difference. So how do you finesse financial recovery in this environment? Well, the program that Shalene referenced is an important step, but insufficient. Healthcare organizations have to own how we create the future, and give you some ideas about how MultiCare is doing this. One is, how do we retain the best and brightest of our team members? How do we make this a place that people want to work? And we're very committed to that. We're committed to rethinking how we recruit and move people into careers. So we have a whole pipeline of people who we're helping them get the education necessary to be healthcare professionals. We're recruiting on an international basis. We're bringing technology to play to support our clinicians and our nurses. You might have seen a story about Moxie, which is a robot that's being trialed at Deaconess that keeps nurses from having to run around looking for supplies, because it does that kind of work for them. So there's a range of that. We're redesigning how patient care gets delivered in a way that allows patients to have more control over their care and gives better support for clinicians so that they can work optimally within their license. And we're working together with other organizations to make sure that we are able to have the ability to discharge patients from the hospital who shouldn't be in the hospital, which has been a significant challenge. Average length of stay has gone up, so how do we manage that? Keeping readmission from happening, discharging patients on a timely basis. So a lot of blocking and tackling and a lot of new initiatives to make a difference. So a sustainable healthcare system is what citizens of the state of Washington deserve, and I think all the hospitals in the state are working to deliver this, but we can't continue to do it at a loss because ultimately we'll cease to exist if these losses continue. So thank you, Cassie.
Thank you very much, Bill. And we've got some great questions in the chat. I want to get through all of our, we just have one more presenter, get through those, and then we'll get to the chat, which is a very informed group of folks today. We're glad for that. I do want to highlight one of Bill's points, which is who the Medicaid population is. That these really are the folks that are the most vulnerable in our society. It's children, pregnant women, people who are living with a mental illness, low-income workers, low-income families, folks with disabilities. That's who is covered by Medicaid. And our state has been very generous in expanding coverage to people on Medicaid, but has not matched that with ensuring that there's access to Medicaid to care for people on Medicaid. And so this is a real investment in making sure that that's the case. But these are the people that are, I think we have a mission to really care for. And so it will be great to have it make more sense. Okay, Dory Untersayer, if you'll go ahead and then we'll move to the questions.
Okay, good morning, everybody. Thank you for having me. My name is Dory Untersayer. I am the Chief Nursing Officer at Harbor Regional Health here in Aberdeen. And in January, marked my 31st year of employment here at this hospital. I've been fortunate to be able to do a variety of things, and I have been in this role just a little over a year. So I would certainly echo everything that Heidi and Bill have talked about. We all share many of the same issues and the same problems, and the challenges, are immense. If you don't know where Aberdeen is here, if you've been to the coast, you've gone through Aberdeen more than likely, since it's the only road to get to the beach. And so we too are a little bit isolated in a lot of respects, like Heidi. And but there are a couple of things that I would like to talk about, just specific to us here. In August, I believe it was, in August of 2020, we closed our surgical unit. I think we were, if not the first, one of the first hospitals in the state to actually close a service line down. Part of that was a couple of different reasons. Surgeries were curtailed, as you all know. So the second floor was our post-op surgical unit. And so we were not able to do a lot of elective surgeries and those sorts of things that we were part of the governor's mandate. So that affected that, as well as the loss of employees. So we closed that unit in August of 2020, and we have not been able to reopen it since then. That's had a huge impact on our organization. Surgical patients, when you cancel or you're not able to do surgical procedures, that has a huge impact on patients. They have surgical problems that go unaddressed, eventually getting potentially to the point where regular interventions that you would do are no longer feasible, and they don't have any effect. The effect that has had on us is that it has led to a sicker population that is coming into our emergency department, and increased our costs as well to take care of patients who perhaps might have been able to have those things taken care of, but weren't able to in the long run. It also affected our surgeons. Surgeons like to do surgery. That's what it is that they do. And so that affected their practices as well. So everything that you see in hospitals kind of has a downstream effect. And we still to this day with the constraints that we have with staffing and operational beds. On a daily basis, we evaluate the surgicals that are scheduled, and we aren't canceling like we did before, but we look at it every day to make sure that we have a placement for those patients. And part of the reason for that is not being able to open up second floor has really had a huge impact on us. We've not been able to open it up at this point because of staffing. So Heidi talked about contract staffing. Bill talked a little bit about that, foreign nurses, those sorts of things. Well, I'll just add a little bit of a twist to that out here on the harbor. We have a little bit more of a difficult time. Part of it is our rural location. Part of it's just the number of people that we have to draw from. So I can tell you that in 2019, our turnover rate was 22.7, and that was turnover rate through the whole hospital. It had gone up a little bit from 2017. In 2020, that turnover rate was 20.2. So we were holding pretty well. In 2021, which was devastating, our turnover rate went to 28.3. So that's not just, wasn't just nurses, it wasn't just CNAs, but that was the turnover rate throughout the whole hospital, included environmental services, included registration. And now for 2022, we're starting to ease off a little bit, 24.4. So that's kind of starting to trend down a little bit, and that's really good for us. But we've had some of the same difficulties that Heidi and Bill had. We still do. Travelers. I'm like Heidi. Back in 2019, we had 2 travelers here at the end of the year. 2. In 2021, that was 34, and currently it's 42. And they don't come without a cost. And believe me, I am grateful for them every day, because that's how we're taking care of our patients. I have travelers that are here, not just RN travelers, but I've got travelers in diagnostic imaging, travelers in the lab, travelers that are respiratory therapists in our cardiopulmonary department. And I couldn't do what we do, taking care of the patients every day that we do. But those costs are unsustainable. We had a $7.4 million net loss last year. So that's not quite as high as Bill's, but again, we're one hospital. But the effects of that are just as devastating. We can't sustain that. A little bit of a mention about supply and utility costs. They've just gone through just skyrocket astronomically, and those are not coming down. In the midst of all of this, someone had mentioned difficulty placing patients. So we had a long-term care facility in Montesano, Washington, experienced a fire last year and closed. And that closed over 75 patient beds that we had access to. And that was devastating for our community. I can tell you that we have struggled to place patients, and we are not a long-term care unit. This is not the best place for someone to be that needs long-term health care. We're good at the short term. In fact, we're excellent at the short-term care, but not so good at those things. And there's nowhere for those patients to go. The boarding of patients throughout our hospital and the emergency department has had a devastating effect. And we don't get paid for those. We continue to provide the care, but we don't get paid for those. And I am here to tell you, if you have a family member that needs long-term care or rehabilitative care, and all of a sudden you can't access that in your community, and you are now looking at perhaps sending that patient, maybe if we're lucky, up the I-5 corridor. We have sent some patients to Oregon. We have sent some all the way to Idaho to find placements. That's a huge disruption to people and to families. And so those are the vulnerable people that Cassie is talking about. And behavioral health patients, it's the same situation. So it is just not sustainable. We are struggling. And if, anything it is that we can all partner together on, we've been working on that for quite a while. But I thank you for the opportunity to just talk about some of our challenges out here.
Thank you so much, Dory. Thank you to all of our panelists. And we've got quite a few questions in the chat. You also are welcome to just speak up or raise your hand if you'd like to ask a question orally. So I'm just going to make my way down them. So starting with Kate Walters, can you please break down how many hospitals lost money, how many broke even, and how many turned a profit in 2022? Eric, I'm going to send that to you.
Yeah, there were 81 hospitals in the survey. 69 of them lost money. 12 hospitals had a profit. And of those 12 hospitals, 11 were rural critical access hospitals. That there was a final COVID relief funding distribution in December of 21. So part of those 11 critical access hospitals making money was COVID relief funding. And also rural critical access hospitals do receive small annual increases in funding. So they haven't gone the 20 years without funding.
Thank you, Eric. And if folks have follow-up questions, please feel free to jump in. Another question, Senator Mazzal's bill to increase Medicaid rate, does that bill become moot with this new agreement? Shalene.
Yeah, I'm assuming, Doug, that you're talking about Senate Bill 5103.
Doug, is that correct? Are you available by audio? Just go ahead, Shalene, and maybe answer 5103.
Yeah, so 5103 was meant to increase the rates that hospitals were getting paid when a patient is considered difficult to discharge, meaning they would no longer have a medical need to be in the hospital. So in that case, 5103 said, we will take that $330 the hospital gets currently and we'll increase it to $700 a day. This doesn't fix the underlying problem of needing to fund long-term care to be able to have placements for these patients. And over time, the legislature said they were uncomfortable with that $700 a day. So that has been removed from the bill. It had nothing to do with the safety net assessment per se, but just the bill fixes some other challenges around billing and payment relating to patients that are remaining in the hospital. However, going back to the safety net assessment agreement, that's what we call it fondly call it in the legislature. Legislators are understanding that the payment rates have been stagnant for too long in hospitals, and increasing us through the directed payment program and the safety net assessment bill is a better way to address that issue. So hopefully that covered your question. We still support 5103. As I said, it's going to fix some payment issues that are kind of unintended consequences of when patients live or stay in hospitals, but it wasn't meant to address overall payment rates for Medicaid.
Great, thank you.
I'll say we're really grateful to Senator Mazzal for leading that work. And Shalene, I'm going to share some of the specifics of the bill, and please correct me if I'm wrong. But one of the things that happens is a patient is stuck in the hospital who is difficult to discharge, and they need ongoing services like dialysis, for example, and the hospital doesn't get paid for them. And so this bill will help make sure that happens. That's correct, right, Shalene?
Yeah, the Medicaid doesn't pay for them. Yeah, that's they would only pay that $300 a day versus the cost of what kidney dialysis would.
So things like kidney dialysis, lab work, x-rays, all the stuff that you're paying on top. So we're really appreciate Senator Mazzal's work on this and his dedication to helping figure out the difficult to discharge issue. Thank you. Okay, question about the math around how much money $1 billion would come back to hospitals under the Medicaid directed payment program. Does it account for the projected decline in Medicaid enrollment with the end of the federal COVID public health emergency? Shalene or Eric?
Yes, it does. We factor that in to the proposal. I mean, go ahead, Shalene.
Oh, and when we are saying that the hospitals need $1 billion, we need $1 billion net. So that's after you pay the taxes and the assessments, and the funds would flow when hospitals are continuing to see Medicaid patients.
And I also will say, just to folks in the media, about the decline in Medicaid enrollment, we're concerned that people are going to drop Medicaid who will remain eligible, who are eligible but just don't know sort of how to get through the process, because there have been extensions and easing up on some of the qualification requirements. So we would love your help making sure people know that if their Medicaid coverage is ending, they need to do everything they can to stay on. The hospital's willing to help them. Their physician's probably willing to help them. The state's willing to help them. There's lots of assistance available because a lot of people will continue to qualify, just not make it through the administrative hurdles of qualifying. Another question, any indication the federal government would go along with the plan? Is Washington's congressional delegation on board? Shalene, you want to take this?
Yeah, so I will say that, this is a multi-step process and we're in probably step 2 of this multi-step process, meaning let's get the bill passed by our state legislature first. I think, Ryan, your question is great around what does this look like longer term? Our next step after this would be to work with the healthcare authority who works with CMS to review and hopefully approve this directed payment program. We know that these programs exist in other states. We are working, we have complied with all of the federal rules of these programs. So the next step would be to go to CMS. And then in terms of the congressional delegation, I think that we will eventually need to brief them. Again, I think the first step is getting this bill through the legislature. And that's kind of where our focus is at the moment. But you've addressed the other steps that we're going to need to do in this process, Ryan. Thank you.
And I will say that our delegation has been very supportive of Washington state hospitals and Medicaid and healthcare for people in the state. So we're hopeful that they will continue that support, but they've been great for us throughout the pandemic on many issues. Another question, Bill Robertson mentioned rethinking how hospitals recruit employees. Are there some specific programs at Washington colleges and universities for training new nurses and other personnel and or attracting them to the profession? And I'm going to ask all 3 of you to respond, Heidi, Dorian, Bill, about what you think is effective in nursing education, recruitment, and retention right now. Go ahead, Bill.
So we found that we work in a state where there's very receptive educational organizations to the challenges we have. Multicare alone partners with 23 organizations, educational institutions in the state, and more than 300 outside the state, which is interesting. We have a broad network that we work with, and they have all been very receptive to alternate ways to provide education, collaborating around on-campus education, helping us build up capacity to recruit people into the profession. We are pleased to work with the Tacoma School District, and we have 2 healthcare high schools that we're actually a part of, which have between them about 400 students every year who are looking at healthcare careers. So you start young because people make decisions when they're kids about where they want to go. So there's an array of, I think, very successful collaborations with institutions, educational institutions in the state. And I'm certain there's more opportunities as we work together to enhance the speed of education and access to education and pipeline into education. But we're pleased with the collaborative approach that we experience.
And Bill, you all correct me if I'm wrong, you all also do a kind of a nurse residency or a new nurse.
Yes.
Pretty extensive bring you into the organization plan, right?
Yeah. So, when physicians go to medical school and they become a doctor, then they go on to a residency where they learn the specifics of whatever they want to do. That doesn't largely exist in nursing. So nurses go to nursing school and then they end up in a healthcare setting. So we have about 600 nurses a year who just come out of education who go into a really robust residency program that lasts somewhere between 6 and 12 months, depending on the subspecialty they're looking at. And so building that pipeline. So that's one of the areas where we collaborate extensively. And of course, we're a clinical rotation site for pretty much every nursing program or allied health program for their students who are needing clinical experience in their own education process. So yeah, lots of ways to create great experience for people to upskill and be ready to work in a complex healthcare delivery system. Thanks, Cassie.
Dory, can I call on you next as a chief nurse about things you do?
You bet. I'm actually excited to talk about this too. We have partnered with many organizations, just like, Bill has said. We do have a local college here, Grays Harbor College, and they have had a nursing program out there since I've been here, so long before that. And we partnered with a consortium of local school districts about 12 years ago. These are high schools, as Bill mentioned, and we started a program, high school CNA program. I had two clinical educators working for me at the time, and so the three of us were the instructors for that program for the first 2 years until it hired its own instructor. So Bill did say, it's never too early to start. And we have done the same thing, with the CNA program. And we have preceptors that come here from the college. Our nurses precept them. We also have a graduate RN residency program, and we have had that education department here and make sure that they handle that. And again, depending upon the specialty that the nurse goes into, will depend upon how long that they are in this residency program. So we have had that for a number of years. I think the biggest constraint, for us is at the college and the number of students that they're able to take just based upon the number of faculty that they have. And they can take, I believe their incoming class can be 35 students. And so Bill probably has an advantage of having a few more schools, around him in his area. We just have one, but we do advertise, we do recruit, and we do pull in people from other areas.
I will, for those of you, some of you heard this on a prior media briefing, but Taya Briley which is general counsel, and she's also a nurse, and she noted in one of our media briefings that it was a lot, the cost of her legal education, what the school had to spend was a whole lot less than the cost of her nursing education, because her legal classes were much larger, that she had to do clinical rotations, the lab equipment required. I think people think about those in reverse, but nursing education is actually quite expensive to provide because of all the clinical requirements. Heidi, anything you'd like to add to this conversation?
Yeah, so a lot of what Bill and Dory said, but like Dory, we only have one college that's 51 miles away that we're able to draw from for nursing, but we do have about 16 agreements across modalities for clinical education rotations, which we do kind of use that as a pipeline, but it seems like the local college has 32 spots per year, first or second year. And historically, because many of our nurses came from Peninsula College, they had 200 plus applicants for their nursing program. For like 20 or 22 spots. Last year for 32 spots, they had 39 applicants. So that tells me the pipeline of applicants is starting to dry up. And why is that? That's what we need to dig down to. So really what we try to do is really focus on grow your own. So we have our own CNA program. So just for nursing, if we can get them into the CNA program, then we offer them education dollars in lieu of time to workforce in exchange for the money spent. And that's right now been our real success.
Thank you, Heidi. Okay, some more questions. Again, from Kate at KOW. Is the Medicaid bill already introduced in the legislature or yet to be introduced? It's not yet introduced. We've been working with the bill sponsors and the technical staff in the legislature and the healthcare authority to get all the language correct. And as someone noted, we've got to get CMS approval to make sure the state bill aligns with the federal law, et cetera. But it should be quite shortly. And the second question, Shalene, anything else you want to say about that?
No, go ahead.
Okay. If this kind of program is in place in other states, why has it not been put in place in Washington before now? We do have a similar program now, but it's very, very much smaller. And so this is an expansion and a redirection to change with new federal law and opportunities for directed payment programs. So it exists, but this is a bigger way of going about it. And we are in fact following the lead of some other states that have gone before us. Any wish of people want to say anything else about those? Okay. If safe staffing legislation passes, what's the concern about the effect on losses or ability to keep units open? So Ryan, we did reach a compromise with the nursing unions on the safe staffing bill. It is a bill that will require hospital adherence to staffing plans, or if not adhered to, require corrective action plans through the Department of Health and the Labor and Industries Department. And if that's not successful could lead to fines. It does not include staffing ratios. We do, however, continue to have concerns about the hospital's ability to staff, and that some of those corrective action plans could in fact require hospitals to close services. So there is some time before it takes effect, but it's the bill will pass almost certainly. We've reached agreement, but it does remain a concern. We come to this conversation with a very strong concern about, can patients get access to the care that they need? What happens if the ER is closed to admissions because the staffing plan is in danger of being breached? That's a real concern. Okay. Anybody else want to say anything else about that? Okay. From King 5, curious about how much of an impact this has had on patient safety. I'm assuming that this here is about short staffing. A DOH study came out some time ago about short staffing regarding nurses may have led to an increase in adverse patient events. How much of this has affected patients, especially down here in Tacoma? So Bill, I'll turn this to you in a minute, but I want to provide a different answer as well. The biggest adverse event a patient can have is they can't get care. So in California, during the COVID pandemic, ambulances were being told not to transport patients to the ER if their chance of survival was very low. Their chance of survival was not 0, it was very low. Their chance of survival becomes 0 if they can't get transported to the hospital. California had staffing ratios. They could not take more patients. You see patients lined up, ambulances lined up outside the ambulance bays in California. And we have seen, because of short staffing, big cancellations of services. Dory was describing this. Patients who are not getting knee replacements, heart valve replacements, colostomy reversals, slow cancer tumor removals. Those are huge impacts on patients' health, both physical and mental health. So it is a big deal. I mean, I think it's a good question, but I think sometimes people miss the bigger context of if the hospital is cannot allow access to care, that is the biggest adverse event a patient can ever have. So Bill, I don't know if you want to add more context to that.
No, thanks for the context, and I agree with that. So specifically related to here in Tacoma, because that's the reference, I'm very pleased to be able to say that we've been on a long journey as multi-care pre-COVID, what we call a highly reliable organization journey, where we seek to build culture and systems and processes that reduce or actually eliminate avoidable harm. And throughout COVID, we have actually seen a declining number of serious safety events. So we measure them at one event, or how many events per 10,000 patient days. We have seen a consistent reduction in serious safety events and safety events in general throughout the COVID experience, because building systems and processes that work. So we don't believe that the direct care has, maybe we can move our agenda faster if we'd had a little better access to staff, but we've been generally staffed to meet the needs of patients. But we've had to cancel services that, as Cassie referenced. So we don't think that we have actually seen, we know we haven't seen an increase in serious safety events related to this.
Thank you, Bill. I'm going to find some of the information about what's happened in California, if I can find it quickly enough, and put it in the chat. But the other issue that happens when hospitals are prohibited from admitting for more patients is that the EMS is either waiting until a patient is discharged or moved into an inpatient bed so they can bring someone to the ER. So the EMS is standing outside and they can't answer their calls, or they're transporting patients more out of the community, which takes them out of the rotation. So then your EMS response times also go up, which is a big adverse event. Okay. Doug has a question that I don't have the context for, so I'm going to Doug ask you a question back.
Sure.
The hospital in Sandpoint, Idaho this week said it would no longer deliver babies. That might put more pressure on the hospital across the border in Newport. How will fiscal pressures at rural hospitals and also I would say Spokane, probably would, Bill, I'm looking at you for Deaconess. How will fiscal pressures at rural hospitals and out-of-state abortion restrictions affect hospitals and reproductive services in Washington's hospitals? Are they not doing this because of finances or staffing, or because they're concerned about how the abortion restrictions intersect with their
I think in this case, it's both financial and lack of people, but we were thinking about how does this, if you get a rush from folks, say in Lewiston or something like that, some of our other border communities where women recognize they can't get the services in their state, is that going to mean a rush at places like Newport and Pullman and that sort of thing?
Yeah, I think we've been, so I want to say, every time I say this, I want to be clear about this. The Hospital Association does not have a position on the federal case. However, we do believe that people need access, especially to emergency services. And we have been concerned about some of the state laws, including Idaho's, that seem to say we can't intervene for a woman until she's like almost dead to save her life. And what that might mean, you know, if you're in a small rural hospital and you have a woman who's totally crashing, how does that affect the Spokane area hospitals? We do know that abortion services are typically not a hospital service. It's mostly a Planned Parenthood, you know, a women's clinic, outpatient clinic service. So it'd be a good question to ask them as well. But I think I'm going to ask Bill what you think about getting from Idaho women in distress who are in labor and how they get to you in Spokane.
Yes, so we operate 2 hospitals in the Spokane region, Valley Hospital, which is actually closer to Idaho, and Deaconess Hospital, which is in Spokane generally. And we have actually seen patients come over already out of the Idaho space. We're prepared to take care of them. We have you know, good resources in the emergency space and the like. But it is unfortunate they can't receive care, you know, in the communities where they are. I will say Northern Idaho has a pretty sparse population, so the number of people who are pregnant likely is not going to be overwhelming. But when we get people who are really ill, it does create, you know, it's a threat to the woman's life and perhaps the baby's life if they haven't already lost the baby when they get to us late in the process, and that's unfortunate. But we're prepared to take care of people who come in, and we have plans to do that. And I know other organizations in that same geography have been taking care of patients who've come across the border.
Thank you.
I just put in the chat a story about how the ambulances in California were being told by their public health departments, just don't bring patients in. There's not room in the hospitals because of the staffing situation. And that's what I mean about the worst possible adverse event is you don't get to get the care you need. I think I have gotten, did I miss anybody's question? I'm sort of trying to juggle questions and moderating. I believe I got everybody. Anybody else? Did I miss anyone? Okay, well, thank you so much to our panelists. Thank you to our media partners. We really appreciate your help in getting these stories out. Also appreciate look forward to getting to work with you about making sure people don't lose Medicaid coverage. I think I really appreciate that question because that's a big deal for people. It's such a stressful thing to not have health coverage. I've thought about this a lot. I have 3 kids and I've been to the hospital in the middle of the night with croup and kids who, you know, a kid who took a header off playground equipment, had a big concussion, like that stress that would be if you didn't have health insurance and didn't have the assurance that you could get the care that you needed for your family or yourself. So helping us make sure people can continue that coverage and have the peace of mind that they can get themselves and their families to the hospital without it being a point of serious stress about whether they should or shouldn't. We appreciate that. All right, any last questions? Okay, thank you so much. We'll look forward to talking to you next time, hopefully with sunnier news.
Thank you,
Bye.
Cassie.
Bye.
Thank you.